as you can see, I'm also socialized in the life sciences, and I need PowerPoint now to illustrate what is a pleasure for me to do today, to kind of portray the different thoughts foot for discussion tomorrow in the book Impact of Healthcare on Character Formation, Ethical Education and the Communication of Values. And there we have quite a variety of topics, and I will introduce you to some of the arguments and thinking. And the 14 chapters in this book, they kind of cluster around four main topics. The first is the tensions between cost pressure and professional, medical and ethical commitment to each individual patient, and how to deal with this in the modern healthcare systems. The second is again a little bit connected to the topic of family decision making, especially in the era of genomic and genetic advances. The third one is the ethical impact, or the ethical questions that are generated by novel technologies and especially digital transformation. And the last part focuses on the important other professions than doctors, such as nursing and pastoral care, which are important pillars in the interdisciplinary team and decision-making with the patient. So the first, and I can kind of highlight some of the chapters and arguments and leave it to the discussion tomorrow, what you want to pick up or dive into it in more detail in the book. The first part of the book addresses the ethical tensions in the healthcare system between professional responsibilities towards the individual patient and realizing them in a complex healthcare system with naturally limited resources, as all institutions are. And these three chapters address the consequences of cost pressure and how they might be addressed on three levels of healthcare provision: the doctor-patient level, the level of the healthcare organization, or the steering level of healthcare system. So Christine Thomas specifies such challenges with respect to the medical treatment of elderly patients. She describes conflicts between the patient and their relatives, conflicts also between the family and the medical team, and addresses a spectrum of potential problems that arise from first unrealistic demands for maximum therapy to a resigned nihilism of frail patients or a laissez-faire attitude on the side of patients or relatives, but also limitations in hospital financing. I set out in a second chapter to define the role of professional ethics for the individual doctor, but also derived organizational ethics requirements in the face of economization or financial incentives of the healthcare system in Germany, where the financial pressure is increasing in the last years. I focus on situations in which cost orientation stands in the way of optimal patient care and put physicians in a position between their mission to primarily ensure their patients' welfare and their responsibility for cost-conscious decisions as gatekeepers of resources. I ask the question which corrective measures are available at various levels of the healthcare system with regard to the medical professionalism on the individual level, the institutional level of healthcare organizations, and the societal and regulatory framework. I stress the professional discretion of each individual physician on the one hand, informed by professional ethics, but also the limits of appeals to a new oath, to individual ethos and personal responsibility, and posit that rationing decisions need to be transparent and located above the patient-physician level. I then propose potential guardrails for ethical decision-making in view of cost considerations. Günther Thomas also starts out with the person-to-person relation and its theological historical background of an ethos of caring for the sick in Christianity, and then portrays how this relation is now embedded in complex network of medical institutions, health insurers, public funding of healthcare. How to orchestrate this complex network with its differing value systems of orientation and the associated expectations. If doctors or nurses are forced to consistently act against their own professional ethical standards, this causes orientational distress, that is his wording. Even more so, it also leads to moral distress and thus to exhaustion and burnout. Just a couple of weeks ago, a landmark article appeared in the New England Journal of Medicine on the connection between mental health and ethics in professions with high moral responsibility, and describes the long-term consequences when people feel they have acted against their own moral values or lose trust in the moral integrity of their organization or society. Part 2 of this book turns to the ethical challenges that come with the advances in genetics and challenges from family decision-making. It also includes a more conceptual paper on the diverse ethical debates on genetics and epigenetics and how gene editing compares to epigenome editing as a result of a DFG-funded research project that I conducted with a wonderful young philosopher, Carla Alex. I won't touch on that chapter, but on Ruth Farrell's report about advances in genomic science and technology that have impacted reproductive health care, particularly in prenatal care, where genetic tests can inform decisions about reproductive health and family planning. However, the complexity and uncertainty of genomic information before birth presents challenges for patients, families, and society. Farrell draws a very nuanced picture. On the one hand, it is important that decisions about the use of genetic testing reflect the values, needs, and goals of pregnant women and their families. On the other hand, these decisions are also embedded and thus influenced by social systems that have significant impact on agency. First, the ability to access genetic testing, but also the options provided to act upon the information and decide to end a pregnancy. For example, if a severe condition has been diagnosed. She not only raises concerns about a woman's ability to access abortion services in the United States if a severe fetal genetic condition is identified, she also considers, and this kind of ties back to the presentation we just learned a lot, whether or not a medical condition is perceived as dysfunction. This is not only a matter of science, but is partly or maybe widely socially determined, in that it is dependent upon the social infrastructure that enables differently abled individuals to interact with their families and their communities. Beate Dietzen and Christian Schaaf anticipate yet another important advancement in medicine, genomic newborn screening. Genomic newborn screening is a screening process that can identify specific diseases in newborns that require early intervention to improve health or save their lives. It would mean a significant expansion of our conventional newborn screening, which currently screens in Germany for 19 diseases. They report about the factors that are important for individuals and family during and following genetic testing in general, and the lessons learned in the pilot project on genomic newborn screening. The pilot project on this topic in Germany, New Lives, is the acronym, takes place here in Heidelberg as an interdisciplinary effort between 5 disciplines. And compared to other countries, to my knowledge, is the only pilot that has a strong emphasis on ethical, legal, and societal questions besides the medical ones that need to be answered in terms of feasibility. And the questions this project wants to answer is: what are sound criteria to select genetic diseases for such a screening program as a public health program? How should the information and consent process with the family and parents be set up? Should genomic data generated in the screening be archived for later use, or should they be deleted? And how altogether should a normative framework and best practice recommendations for a genomic newborn screening look like? The authors suggest concrete communication strategies along 5 dimensions: severity of disease, probability of outbreak, efficacy of intervention, burden of intervention, and knowledge base. In the New Life project, these dimensions are currently factored into a framework that allows for the benefits of early intervention on genomic screening and tries to prevent potential negative sequelae. While this part, the second part, is obviously about progress in genetic technology, the third part highlights progress in neurotechnology, stem cell therapy, and of course the field that is currently particularly debated in ethics, digital transformation. So Andreas Unterberg and Pavlina Lenka report about the technological, oh no, I switched the sequence. Anthony Ho first illustrates in 3 case stories, situations that raises ethical consideration about experimental treatment with unknown risks in palliative patients and the inherent tension between palliative care and early phase clinical trials. The second case is a success story about a patient who also received a new experimental treatment, a stem cell transplantation, but still it raised ethical questions about the justified price of a novel product and profit margin for the pharmaceutical industry. And a third story highlights the detrimental impact of premature communication of not yet consolidated scientific evidence on clinical decision-making, and too early adoption of a hype. So the seminal contribution by Giovanni Rubais and Nadja Primsch on digital transformation asks, how can digital disruption of healthcare be avoided and a process of incremental change and intended improvement of healthcare be implemented? They identify 3 guiding strategies or positive developments, first kind of following a participatory technological design, transparency of parameters of an algorithm-based system, and continuous improvement of health literacy. It concludes with a call for respect of the autonomy of patients, the promotion of well-being of patients, and the prevention of inequality of patients. And now I think I lost one of the slides and report on the neurotechnologies of Andreas Unterberg and Pavlina Lenka and the advances in surgery there. They nicely exemplify how the also mid-level principles of medical ethics help to navigate the kind of difficult decisions, weighing of quality of life, survival time, and other patient-oriented factors using different disease scenarios and comparing different evaluations. One was an example of glioblastoma as a very aggressive brain tumor where surgery can restore such quality of life, as opposed to the course of benign tumors where surgical resection can lead to worsened quality of life. So the contributions in part 4 show the value and worth of different professional perspectives that enrich discussions and support on the bedside. Gregor Etzelmüller addresses the human search for health beyond the experience of physical healing. He works with Victor von Weizsäcker's insight that patients challenge physicians to expand the boundaries of their professional expertise by asking, quote, for the destiny of their lives, unquote. One way to expand the professional expertise of physicians is to give nurses much more of a say, and this is what Karen Nolte does in her chapter that shows the simmering crisis of the nursing profession today, and that has been acute within the COVID-19 pandemic. Everybody applauded the nurses, and now the situation after the pandemic hasn't become any better. And she takes the look of an historian to the development of the profession of nursing. Up to the middle of the 20th century, nursing in Germany was organized in sisterhoods, most of them connected with Christian denominations. Florence Nightingale formulated as a pioneer for the nursing professionalism a more secular ethos with a strong medical emphasis. A quote from her says, "Good training in nursing should serve to combat illness as well as poverty, including spiritual poverty." Hence, she and nurses emphasizes their professionalism and demand appropriate recognition of their work and adequate pay, which is a quite current topic still. I think we see here a professionalization of the whole field. Also, University of Heidelberg and the medical faculty has set a focus on expansion of health professions with several new professorships in physical therapy, in nursing and oncology. So I think this is now taking up pace, and this is a good sign. Another strategy to expand the perspectives and support for patients beyond the physician are clinical ethics committees or consultation services, which have now become an integral part of decision-making and advice in difficult situations. Thorsten Moos explains why ethics in the clinic has experienced a boom in recent decades and emphasizes the potentials of pastoral competence in dealing with different ethical convictions, not only among patients, but also among clinical staff. It has led to a strong investment into pastoral care education and a new climate of integration of hospital chaplains in institutional counseling services, such as clinical ethics committees, to sort out reasons and arguments and emotions and discuss next steps. He stresses the complicated but morally highly valuable goal to give, quote, the patient a voice in the conflict between doctors and relatives, unquote, and in situations of deep personal distress and great difficulties in articulating their own will. The final chapter by Peter Kirsch addresses the question of conflict resolution in the field of psychiatry. He reports the great challenges of psychotherapy, and that they lie in the difficulties to help people to become aware of their basic needs, values, and resulting goals for action. Psychotherapy has to avoid paternalistic approaches and has to take the patient's autonomy and self-determination seriously, very much aligned with the goals of clinical ethics committee and consultation. So in summary, the contributions in this volume offer a wide range of challenges to medical ethics and values that can be clustered around these four main topics. You have seen that the topics are quite complex and a variety, but that there exist also helpful ethical guardrails to balance different values. And I hope I have made you want to delve deeper and pick up the book every now and then. Thank you.